ahead and get started. So first I want to start with an update about what changes are happening with regard to the LDH testing program. As everyone knows, since early in the pandemic, LDH has provided support for staff and resident testing in nursing homes and other long-term care facilities because the residents are such a vulnerable population in terms of exposure because of the setting in which they live, and also in terms of severe health outcomes because of the vulnerable nature of their health. And so we really wanted to prioritize these individuals as CDC learns how routine testing can help with early detection and then rapid prevention of transmission. These practices were implemented, they became CMS guidelines, and they were implemented really across the board in Louisiana. And LDH supported by funding contracted labs that would perform PCR testing, and also sometimes strike teams that would go out and actually conduct the sample collection for facilities that were unable to do so. Now we're more than 2 years into the pandemic, and what we wanted to do was really understand where facilities were with regard to the type of testing they were conducting and what resources they were using. So Andrea Salinas on my team spearheaded a survey that was administered by my regional epidemiologists that are in the regions, and then other folks that helped out on the regional teams. And they spoke one-on-one with as many of the facilities as they could reach to really understand what was happening. And across the board, certainly there's variation from one facility to another, but across the board, they were able to have in-depth interviews with more than 150 facilities, and about 90% reported receiving antigen tests from the federal government. Now, a lot of these facilities that were receiving these rapid tests from the federal government were actually also utilizing the LDH contracted team. So in some cases, they were only using a handful of the tests that they received from the federal government, or they were stockpiling those in the event that they needed them, but really were relying, a lot of the facilities were still relying on the LDH contracted team. Many facilities also reported when they shared their testing practices with us, we realized that a lot of them were testing more than they actually needed to in terms of the routine testing for staff. And so that's another reason that as part of this update, we wanted to provide an overview of the most updated testing recommendations, the guidelines from CMS, which align with the recommendations from CDC, because they're very challenging to keep up with. And so we wanted to really be able to have in one place, both in the resource document that I've referenced, and then also in this PowerPoint, a quick reference so that folks could, better understand what the most updated recommendations are. So, as LDH and CDC and other state health jurisdictions are planning for this broad transition from public health emergency response toward activities toward normal healthcare operations. Now, what does that mean? For us, from a public health standpoint, if we're talking about viral respiratory pathogens, which COVID is one, we're talking about standard operations in terms of testing that the Office of Public Health, the Louisiana Department of Health, supports testing for public health purposes. We don't provide across-the-board diagnostic testing. So, for example, what this looks like with flu, and what we anticipate in the long term, what this will look like for COVID as well, is that when we identify a problem within a facility, for example, if there is transmission that is occurring within a facility, then we want to be able to use our public health resources, which are becoming more limited with regard to COVID, for public health purposes, because diagnostic testing is widely available. Nursing homes are receiving rapid viral tests from the federal government. In terms of the general public, testing is available in so many places. CVS, Walgreens, there's still some community-based testing sites. So where public health needs to go is to really move back to the stance of testing for public health purposes, so we can really focus those efforts and then target interventions based on the results of those investigations. So that's in general the direction that we plan to move. So in planning for that and in response to that strategy, the LBH contracted lab testing is going to be discontinued as of May 13th. Now, we do know that this is just Friday, and it's going to sneak up on us before we know it. So we are prepared, certainly, for facilities, for example, that do not have enough supplies from the federal government to fully support the routine staff testing that they need to conduct. We're going to be there to help support and make sure you have perhaps additional rapid tests that we're able to provide, or if we need to extend for certain facilities, work with some of the contracted labs on a limited basis. We'll work with you to make sure that you have the resources that you need, the nursing homes have the resources they need through the end of May in order to really make that transition a little bit easier and more comprehensive. After that time, the contracted labs will certainly not be available for this purpose. But where there is a gap, where the federal government is not completely meeting needs with regard to staff testing, and keep in mind the federal government program is only for staff testing. Resident testing should be accounted for through Medicare and Medicaid private insurance. So it's just a staff testing where there's this gap. And if enough tests are not received from the feds, then you can reach out, and you see in the slide here, I have the email where folks can reach out for additional help, and that's COVID testing at la.gov. And I know Kelly Finwall and Danae Butler can also assist with this directly. I believe Kelly offered to share her email address, which Kelly, if you don't mind putting in the chat, that might be helpful because I didn't get it on the slide. And then, of course, for public health guidance related to technical assistance in terms of infection control, or perhaps assistance with identifying the folks who, where there's an attempt to conduct maybe targeted contact tracing. If there's a single case, for example, a staff member that's been identified, our public health epidemiologists and infection preventionists from the HAI team can assist with that. So before we move into the actual testing recommendation update, I wanted to review two components that are key to driving and informing the public health, the staff testing cadence, but also masking recommendations. And these two components are vaccination status and community transmission. So first, vaccination status, because it's the easiest. And this is a change, and this is really why I wanted to highlight this. The previous guidance used to use fully vaccinated as the sort of benchmark for staff to be exempt from routine testing. That has changed. It is now only staff that are considered to be up to date with their COVID vaccines that are exempt from the routine testing. Now, what does it mean to be up to date? I have this chart here. This is the chart for recommendations related to the schedule. Of course, the schedule that's recommended here, just in case for general knowledge, really applies to folks who are not immune compromised. But in general, this is the recommended cadence, and this is what will be used for determining whether or not somebody's up to date, regardless of whether or not they're immune compromised. So resident or staff member is considered up to date immediately after receiving their booster dose. Up to date means you've received all of the doses that are recommended for you. And as we know, for everyone 12 and above, we're recommended to have the primary series and then at least one booster dose. And so someone is considered up to date immediately after receiving their first booster dose. If they have recently completed their primary series and they're not yet eligible for their booster dose, they are still considered up to date because they've gotten all of the doses they're eligible for. Once they're eligible for that booster dose, as soon as they receive it, they will also be up to date. If they don't get that booster dose when they're eligible, then they're no longer up to date. And so it's only staff members who are not up that are up to date, that are exempt from the routine staff testing. Now, the other factor that drives testing is related to community transmission. There has been a lot of confusion about community transmission lately because CDC introduced a new indicator called community level. And what I really wanted to highlight is that community level is meant to be used for individuals and the general public and in community settings like K through 12 schools or colleges. Community transmission is meant to be used in healthcare settings. There's a higher standard for preventing introductions into these settings, and so community transmission is what is used. I'm going to explain these differences a little bit more, but these settings include hospitals, long-term care facilities, clinics, certainly parish health units if you're talking about public health. So here's a little summary of the community transmission indicator. This is the one that's been around the longest. It was first released in September of 2020, sort of fairly early on in the pandemic. And it really uses two metrics to define and make a determination about the categorization of a particular geographic area's community transmission. And that is the total new cases per 100,000 in the past 7 days. We refer to that as incidence, or the percent of PCR tests that are positive in the last 7 days. We refer to that as percent positivity. So it's really the higher of these two that drives the classification for community transmission. And generally that tends to be incidence with the number of new cases per 100,000. Now, community transmission, before community level came out, community transmission was used to inform all of the CDC recommendations, both for the general public and setting-specific guidance across all settings. But now, as I said, this one is limited to healthcare settings, which include nursing homes and other long-term care facilities. Community transmission is actually rightly used for this purpose because it is the best measure for evaluating the risk of introduction of COVID-19 into a facility and then the subsequent spread within that facility. And because we're talking about A, vulnerable populations, and B, settings where transmission can occur very quickly and very easily, that is why we need to use this indicator because that's going to really allow us to prevent an infection from being introduced. So here's the link to the CDC COVID Data Tracker where you can find both community level and community transmission. And Andrea is going to give a little bit of a demonstration later about how to navigate. It's not necessarily intuitive, so that you can have a little bit more information, be a little bit more familiar with how to find it. And also, Andrea has outlined a step-by-step process for navigating to community transmission in the resource document that I mentioned. So this is a summary of community level. It was released just in February of this year, and what it is it represents CDC wanting to sort of refocus and make a transition. At the beginning of the pandemic, before vaccines were available, really the priority was eliminating transmission to the greatest extent possible. Now CDC, for the general public, is transitioning to where they're trying to, instead of thinking that there can be this overall elimination of transmission, they want to prevent medically significant illness. They want to preserve the healthcare system capacity and protect those at greatest risk. Well, protecting those at greatest risk in nursing homes really means using community transmission, and that's why CDC makes the recommendation there. The community indicators, correspondingly, the indicators that are used for community level include new cases per 100,000, but it's a mixture between that and also the percent of staff inpatient beds that are occupied by COVID-19 patients and the new admissions per 100,000 over the past 7 days. So there really is this focus and this taking into account of the capacity of the healthcare system and whether or not a burden is existing there. It's not just related to the risk of transmission and the risk of infection. So as I said before, this community level indicator is going to inform public health recommendations for the general public and community settings. And I just want to show you the difference between what our state looks like if you're looking at community level versus if you're looking at community transmission. This was, I think I pulled this Friday. Community level, you can see Louisiana is all green. And that's because, largely driven by the fact that our hospitalizations are currently low, and those new patient admissions are going to be low. Although I will say this, they're starting to uptick a little bit, just for your awareness. But every parish in the state has a low community level. By contrast, this is community transmission. There are about 8 or so parishes that are in substantial or high transmission, and we'll get into this later. But remember, for nursing home testing purposes, facilities that are located in parishes with substantial or high community transmission, that prompts twice weekly testing for staff that are not up to date. So this is important to realize that we're seeing increases in community transmission. About a month ago, all of our parishes were most of our parishes, I think 44 of our parishes had low community transmission, and the remainder were in moderate. We had none that were high or substantial. It's important to keep monitoring this because it's going to really be important to understanding how frequently you need to test. And community transmission is the map that should be used by long-term care facilities. Okay, so this is where I'm going to stop sharing my screen momentarily. And Andrea, if you don't mind, I do think it would be useful for you to show folks how they can navigate to community transmission on the CDC COVID Tracker website.
So I can do that if you give me co-host again, because I got kicked off and I had to reconnect. Oh. Okay. Okay, can everyone hear me?
Yes, I can hear you.
Okay, cool. So this is, well, first of all, I want to say the link Teresa provided in the presentation, it ends in the word risk, and also the link provided in the document that Teresa has referenced a few times, that link also ends in the word risk. That will take you to the appropriate map with the community transmission levels, but I did want to start with the default map. If you're navigating to this website, to the data tracker a different way, you might end up on this, this website, starting with the community levels. This is the default when you navigate through the data tracker. So what you'll want to do if you're on this map, you'll want to change the data type from community levels to community transmission. And to get to the community transmission, you will have to scroll down. This will load a new map. Hopefully, okay, there it is. So here is our community transmission map. As you can see, it's way different than the other one. It doesn't use green, it uses blue for low. And there's 4 colors instead of 3 for this one. To look to see what your parish level is or transmission is, you'll want to probably zoom in here. You'll use these plus minus symbols, and then you can move the map by just clicking in here and dragging, and then it will display your parish name if you hover over the parish. So if you're unsure of the location of your parish, you just hover over here and it will tell you the name of the parish and the transmission level. So in our document, we recommend that you're checking these weekly because some of the triggers for going up and down are going to depend on a weekly change. And we recommended that you choose 1 day a week to look at these because these will update daily. It's using a 7-day period. It's a 7-day look back, but it will change. It has the potential to change daily. So if you forget one day, or it was a holiday and you weren't in, and you need to look back on the day that you're supposed to look at, you can go back using this view a time lapse. If you click view a time lapse here, it'll open a new map. This one's a little bit more advanced, so it's going to take a little bit more time to load. And you can navigate to the date you're wanting to look at. So say, you didn't do it last Monday, 5/2. This will load your new day. And the same thing, you can zoom in here. You can drag your map over to orient it to where you're wanting to look at. And again, you can look at the transmission level, the transmission levels of your parish by hovering your mouse over the map. So as you can see here, this is just 1 week ago. It's very different. And you can go back as far as, what is that, a month you can go back. If for some reason this is moving, because this is a time-lapse map, it shouldn't automatically give you the time lapse, but if it does, you'll just have to press this pause button here to make it stop. So it's going to start going through the days, and you just press the pause button and it'll stop to where you want to go. You just need to re-navigate to whatever day you're looking at. And not intuitive, but once you get the hang of it, it is pretty simple.
Thank you very much, Andrea. And I really appreciate it, because I actually didn't even know about the time-lapse map until she and I started talking about this. So, okay, I'm going to share my screen again. And I'm going to keep going. Okay, so we did that. All right, so now we're moving into the actual testing guidance. And so there are 3 types of testing that I'm going to cover. One is routine testing for staff members who are not up to date. The other is testing regardless of vaccination status for anyone who presents symptoms or reports symptoms that are consistent with COVID-19. And then the last is going to be testing in the context of an outbreak. So first, for routine testing, and I know Andrea covered some of this already, but just so you know, one of the things that we did see is we think that some folks are testing residents on a routine basis, even in the absence of an outbreak, and that is not recommended. So the only folks that need to be tested on a routine basis in the absence of an outbreak are staff members who are not up to date. There are a few exceptions, such as newly admitted residents and residents who've left the facility for more than 24 hours, and the recommendation is there for them to have a series of 2 viral tests. And if I say viral tests, that means it can be antigen or PCR. Sometimes, depending on the result of the antigen test, requires a confirmatory PCR, but we'll go into that a little bit later. But in general, it's really the staff members where most of the routine testing is going to occur. And routine testing of staff, again, who are not up to date with COVID-19 vaccination, should be based on community transmission level. Staff who are up to date do not need to be routinely tested, nor do those who have recovered from a SARS-CoV-2 infection in the past 3 months. CDC, and this is something that has been fairly consistent at least for over a year, which is that they think that folks who have been infected within the past 3 months are fairly well protected. And also, if you're talking about a PCR test, they're also likely to continue to test positive for up to several weeks afterwards, because as we know, a PCR test is looking for genetic material, SARS-CoV-2 genetic material. It's going to pick up bits of material. It's not always just going to pick up a culturally competent virus that's capable of replication. So it could just be someone who's still testing positive, but they're actually not infectious. So here's the testing frequency recommendations according to the community transmission level. So if you're thinking back to that map, there's low, moderate, substantial, or high. Low is blue, and there's actually no recommendation for testing staff who are, whether or not they're up to date with their vaccination. Even if they're not up to date, if community transmission is such that it is low in the parish in which your facility is located, there's no routine testing of staff. Moderate requires testing once per week, and substantial or high, as I mentioned, that triggers twice per week testing. Now, just a little footnote here, staff who work infrequently should be tested within 3 days prior to their shift, which includes the day of their shift, if they're not, working consistently, several days a week. So Andrea mentioned this a little bit. The idea is to check 1 day per week, ideally the same day per week. If you forget, you can use that Timelapse feature that is new to me that Andrea shared with everyone. But if your facility moves to a higher level of transmission, then the testing frequency should immediately shift to match that higher level of transmission. However, if when you go to check on your prescribed day of the week, if your community transmission has decreased, and it would decrease the frequency of testing, don't decrease yet. We want to see, and I'm including myself with CDC and CMS, they want to see that the community transmission stays at that lower level for 2 weeks. And if it stays there for 2 weeks, then you can go ahead and decrease your level of testing frequency to match that lower community transmission. And this I wanted to highlight, perhaps I should have put it earlier in the presentation, but I just wanted to show folks what we're talking about with regard to the number of staff members that might need to be tested because they are not up to date. Because this is really an area where some substantial improvements can be made that will not only better protect that staff member, better protect the residents, but will also decrease by an incredible amount the amount of testing that needs to be performed. So if you're just looking statewide, over here, this is staff, vaccination status on the right-hand side. This green portion of the bar, that represents the percentage of staff, of nursing home staff members statewide that are reported to be boosted. And for the most part, everybody's pretty much eligible to be boosted at this point. So it's only 26.5% overall, and certainly it's higher in some areas than the others. The other bars represent specific public health regions. But only 26.5 would be exempt from routine staff testing because they're up to date. So the more encouragement and incentivizing and the more progress that can be made with those staff members that are not yet boosted but are eligible to be, the less they'll have to be tested and the less testing will have to be performed on the part of the nursing home. So I did want to just flag that for everybody. Okay, so now we're moving into symptomatic testing, which doesn't take vaccination status into account because residents and staff, and this goes for the general population as well, anyone with signs or symptoms of COVID-19, regardless of vaccination status, needs to be tested immediately. And of course, appropriate measures for isolation or exclusion from isolation, proper isolation of a resident or exclusion from the workplace for a staff member until the results of that test can be, that are available, needs to happen. Antigen tests can be used for this purpose. But this is where I mentioned there are some situations where an antigen test needs to be confirmed by PCR. And one of those situations, if you have a symptomatic individual and they test negative on antigen, because sometimes you can have positive and negative, false positive or false negative tests on an antigen, those negative test antigen results on a symptomatic person need to be confirmed by PCR as soon as possible. We want that second confirmatory sample to be collected within 1 to 2 days. I prefer within 24 hours, but certainly no later than 2 days. And again, we need to make sure proper precautions are instituted, especially if we need to wait on the confirmatory results from a PCR test. If the confirmatory PCR is positive, then that individual needs to be considered to be infected. A positive antigen test in someone who's symptomatic does not need confirmatory testing, and that person should go ahead and be considered to be infected with SARS-CoV-2. Okay, moving on to outbreak testing guidance. So, outbreak, as you all know, outbreak in the context of a nursing home is considered by CMS and CDC, is defined by CMS and CDC in different ways than we typically think of an outbreak. If we're thinking of a flu outbreak, or if we're thinking of a norovirus outbreak, usually it's more than one single case. It's going to be, a couple of cases. But in this context, because of the devastating consequences that SARS-CoV-2 has and can continue to have on this patient population, we have a very, very low threshold, right? So even a single case in a resident or staff member triggers some additional testing. Now, there are two options. One is that testing can be targeted in conjunction with contact tracing. If a facility is able to complete contact tracing, identify a case of close contact, then the residents and staff that have been exposed, that are considered to be exposed, need to be tested, and this is regardless of vaccination status. If this testing reveals additional cases, then you need to expand the scope of the testing. Facility-wide or group level, for example, just a particular unit or a particular floor, other specific areas that a facility determines might have been impacted, that approach can be considered if all potential contacts can't be identified. And sometimes we understand, and through the nursing home survey, it was reported to us that some facilities don't feel they have the capacity to do that level of contact tracing. So in that case, there are two options. If it's perhaps just some guidance that's needed in order to help understand where they need to start and where they might need to focus and what questions they need to ask, then our regional epidemiologists and folks from our HAI team can assist with that effort. If, however, more is needed and that just does not seem to be feasible, then that's when the broad-based testing needs to be employed. And so that's performing testing for all residents and staff, either facility-wide, or if it's only one unit that's affected, then that particular unit. And this, again, is regardless of vaccination status. You want to do it not sooner than 24 hours after exposure, but fairly immediately. Usually it's at least 24 hours before an exposure has even been identified, so it's not that piece usually doesn't enter into account. Usually by the time someone tests positive and contacts are identified, then it's been at least 24 hours. So you can go ahead and test immediately, and then if negative, again, 5 to 7 days later. If there are no additional cases that are identified during this broad-based testing, then outbreaks can be discontinued after 14 days on the condition that no additional cases have been identified. If additional cases are identified, testing needs to continue until you go 14 days with no new cases that are identified, and testing needs to occur every 3 to 7 days, depending on the number of tests, the number of positives that are identified. If a large number of positives are identified, you want to use that shorter time frame, and you want to test frequently because you know that there might be widespread transmission occurring, and you need to move quickly to detect those new cases and isolate and quarantine as needed. And also, if antigen testing is used, then more frequent testing should be considered. So I wanted to just go over the confirmatory testing again. So there are two situations when antigen testing is being used where a PCR needs to confirm that antigen test result. And that is when an asymptomatic individual tests positive by an antigen test. And that's important, especially for the residents, for example. As I said, we have false positives and false negatives with an antigen test. The PCR is really the gold standard. So when we have discordant results, we're going to rely on the results of that PCR test. If an asymptomatic individual tests positive, we want to confirm by PCR. Think about what might happen if a resident tests positive on antigen, but it turns out to be a false positive. If they happen to be cohorted in a room with another person who is actually a true positive, then they have a really high risk of becoming infected at that point when they were not infected to begin with. So that's when we want to do that confirmatory testing if an asymptomatic individual tests positive on an antigen test. Again, as we mentioned when we were talking about testing following symptoms, if a symptomatic individual tests negative on an antigen test, we want to have confirmatory PCR there as well. So again, this is about the time frame. The time frame is very important. We would like to have specimens for confirmatory testing collected within 24 hours after that initial antigen specimen was collected. It can be up to 2 days. Again, I prefer it to be sooner than that if possible. If you've got more than 2 days, then what happens is you could potentially have another exposure that occurs, and you don't know if that PCR is positive, if it's related to potentially a new exposure, or if that original antigen test was actually a false negative. And so that complicates the situation in terms of contact tracing. So really need to have that specimen collected within 2 days, ideally 24 hours. Okay, so I did just want to talk that concludes the update related to the testing overview. I did just want to, I know that I went through it fairly quickly, but again, we'll have that resource document which includes all of this information all in one place for you all. And I think that's going to be a good quick reference guide. But I did want to talk about a reporting update because in the survey that we conducted, there were a lot of questions and concerns about reporting. And one of the questions was related to some new HHS guidance that came out, I can't remember, it was a few months ago maybe. HHS used to require on a federal level reporting of all SARS-CoV-2 tests regardless of type and regardless of results. And they have changed that. What the big change is that antibody tests, regardless of whether or not they're positive or negative, no longer need to be reported. And this is a federal guidance. In addition, antigen tests do not need to be reported if they're negative. They only need to be reported if they're positive. PCR tests, regardless of results, if they are positive, if they're negative, if they're indeterminate, if they're critical, those need to be reported to us, all of them. And so we are aligning with that HHS guidance in terms of these changes in reporting. So as facilities, and I presume a lot of facilities are going to shift toward using the antigen test for the routine staff testing, you will not have to report the negative test. We'll only need to report the positive test. So I think that's going to certainly make that reporting a little less burdensome. I just wanted to touch on masking, as I mentioned at the beginning when we were talking about being up to date, and we're talking about vaccination status and community transmission being two components that were important in determining staff testing. And it's also important for thinking about masking. And so I did want to just cover this quickly. Basically, CDC, and this is straight from CDC guidance, CDC recommends source control or masking and physical distancing in any healthcare setting as is feasible. Now, they do allow for certain sort of exclusions or exemptions from this masking in certain situations. But these situations involve when the community transmission is either low or moderate. Substantial or high community transmission, the risk is such that really these situations where it would otherwise be exempt, you need to mask in those situations. And it also includes the individuals involved being up to date with their COVID-19 vaccination. So you can see that some of these situations are healthcare providers who are up to date with all COVID-19 vaccines. They could choose not to wear source control or physically distance if they're in areas that are restricted from patient access. So if they're in meeting rooms or a kitchen, still, regardless of vaccination status or community transmission, when they are in patient care areas, they need to mask. But again, if a healthcare provider is not up to date, or if a facility is in a parish that's experiencing substantial or high transmission, then this exclusion does not apply. Patient visitation, I'm not going to read all of this, but essentially if the patient and their visitors are up to date, and again, I would take community transmission into account here as much as possible, keeping it at substantial to a high transmission where you really are encouraging everybody to mask regardless of vaccination status. And then residents, and this specifically applies to nursing homes, who are up to date in areas of low to moderate transmission, they can remain unmasked in communal areas of the facility. But of course, even in areas where they're experiencing low to moderate transmission, residents who are at increased risk for severe disease should really still consider continuing to wear source control. So I just wanted to go over that. That's very, very quick. You'll have the resource here, and then I have included the link for the full detailed guidance. I just wanted to acknowledge some folks who have been very, very critical